Okay, today we'll discuss dermatology.
Yeah, sure.
Okay. The first question is which one of the following statements is false? Stratum basale is the deepest layer. Synthesis of keratin mainly takes place in stratum spinosum. Woodland bodies are found in stratum corneum. Stratum corneum is a nuclear dead cell layer. So the answer will be number C. Woodland bodies are found in stratum corneum. So epidermis of the skin has 4 layers. Stratum basale, or we call it germinatum. Deepest most layer having single row of columnar epithelial cells actively dividing layer. Actively dividing cells are present here. That's why we call it germinatum. Stratum spinosum, also known as prequel cell layer. This term is very important because many a times in FMG they do not call it directly stratum spinosum, rather they call it prequel cell layer. So polygonal in shape, these cells present in stratum spinosum or prequel cell layer are polygonal in shape, and synthesis of keratin mainly takes place here. Synthesis of keratin mainly takes place here. So each of these information is very important, like single row columnar epithelial cells are found in stratum basale. Actively dividing layer, which one of the following is actively dividing layer? So stratum basale is the actively dividing layer. Deepest most layer, very important, deepest layer is stratum basale. Okay. Next, stratum granulosum, which is diamond shaped. Stratum granulosum, this layer granulism is diamond shaped microscopically. There is a presence of keratohyalin granules and woodland bodies. Woodland bodies coating granules. Okay, and this answer will be actually stratum granulosum. Woodland bodies are found in stratum granulosum, and this statement is false. Stratum, not stratum corneum. So the answer is C, because they have told which one of these is false. Stratum basale is deepest layer, yes. Stratum spinosum, synthesis of keratin takes place, yes. Synthesis of keratin takes place in stratum spinosum. That is correct. And about stratum corneum, we will talk about stratum corneum. It is known as horny cell layer. Again, this term is very important. Horny cell layer, most superficial layer of the skin. More superficial layer of the skin, and this layer is a nuclear dead cell layer. Very important. This is the most superficial layer and nuclear dead cell. Nucleus of these cells are dead ones. So this stratum corneum is this layer, and above that also dead cells flaking flakes, skin flakes stays. The skin flakes that we have above the skin are above the stratum corneum. Above the stratum corneum, they falls off. They simply falls off. So stratum corneum is a nuclear dead cell layer, very important, and it's true. Woodland bodies are found in stratum corneum. No, this is incorrect. Woodland bodies are found in stratum granulosum. Stratum granulosum. So these facts are very important. Another thing is important, like lamellar granules are found in stratum granulosum. Granulosum. Then keratinocyte are found in spinosum, stratum spinosum layer. Merkel cells are found in stratum basale. And as the keratinocytes as the age increases, their level gets up. Level increases. Level means the they move up. They move up the layer. So this starting layer is basale. Starting layer is basale, which is actively dividing layer, which is actively dividing layer. Actively dividing basale, and below that is dermis. So this is all about epidermis. This is all about up from basale to corneum is about epidermis. Another important thing is stratum lucidum. It is only found in palms and soles, not in other places. Palms and sole. It is located between granulosum and corneum. Between granulosum and corneum, this lucidum. Lucidum is not found in any other place. That's why palms and soles, you can see, it's more thicker than any other place. Stratum, granulosum, and corneum. Between these two, lucidum can be present. And this is present only in palms and soles. Palms and soles. Palms and soles. Okay, so this is about epidermis. Questions, direct questions do come from epidermis, from these layers of epidermis. Okay, so next question, next slide, see. Okay, more things are there about epidermis, like keratinocytes. Keratinocytes, these are considered as the principal cells of epidermis because they proliferate in basal layer and differentiation occurs in spinosum and granulosum. As they are present in granulosum, you see, they are present in granulosum, but they proliferate in basal layer, basale, stratum basale, and then the differentiation differentiate in spinosum and also in granulosum layer, also in granulosum layer, which further matures fully and dies in corneum. So keratinocytes are present in all the 4 layers of epidermis. So basically, according to their in the full cycle of keratinocyte, life cycle of keratinocyte, they are present from basale to spinosum to granulosum to corneum. So all these 4 layers are touched by keratinocyte. Are touched by keratinocyte once in its life cycle. Once in its life cycle. So first it start from basale, then spinosum, granulosum, and corneum. Next, melanocyte and Merkel cells. Melanocyte and Merkel cells are present in basale. Melanocytes synthesize melanin, as you know, pigment, and transfer to keratinocytes, and Merkel cells for touch sensation. These Merkel cells are for touch sensation. Touch sensation. Okay, also known as touch cells, and Langerhans cells found in stratum spinosum. Stratum spinosum Langerhans cell found in stratum spinosum act as APC. APC means antigen presenting cell. That means Langerhans cell found in spinosum. Another type of cell is there that is called Langerhans cells. APC they bind with any antigen and they present it to T cells. They present it to T cells for further for immune starting of the initiation of immune reactions. Okay, so antigen presenting cells. Antigen presenting cells, Langerhans cells, are present in spinosum. And another thing is that they contain tennis racket shaped granules, also known as Barbeck granules, in this spinosum. They contain tennis racket shaped granules known as Barbeck granules. Okay, so this is about epidermis. Next question. Acantholysis is lysis of the basal cell layer, separation of keratinocytes, thickening of granular layer, thickening of corneum layer. And the answer will be separation of keratinocytes. Keratinocytes. So acantholysis simply means keratinocytes, separation of keratinocytes. Separation of keratinocytes. Separation of keratinocytes. Okay, this is the picture, typical picture of acantholysis, the appearance, the gross appearance of acantholysis. So keratinocytes are connected to one another by intracellular desmosomal bridge. Intracellular desmosomal bridge. And if there is loss of this desmosomal bridge, it will lead to separation Separation of keratinocytes, and the condition is known as acantholysis. So separation means separation from each other. Separation of keratinocytes from each other by losing these junctions of the cells. That is, this bridging of the cells, desmosomal bridge. Intracellular desmosomal bridge are present normally, but if they get lost, then these intracellular connections will get lost, and keratinocytes will get separated from each other. And this condition is known as acantholysis. This is a typical histologic feature. The typical histologic feature in this picture. You see, these keratinocytes are lined and they are joined with each other. But when they lose intracellular desmosomal bridge, they just got separated from each other. And this will be the gross appearance. As a result of which, this will be the gross appearance, and if separation continues, there will be intracellular edema, and the condition is known as ballooning. Condition is known as ballooning. And this is another picture. This is a schematic diagram as also. This is a real picture, histological picture. It's a real histological picture. This is gross picture. This is histological picture, and this is a schematic one. Okay, other things that are the other terms that are quite similar to acantholysis, sounds like similar actually, like acanthosis. Acanthosis, thickening of the stratum spinosum layer. Thickening of the stratum spinosum layer. This acanthosis is quite found in some diseases like PCOS. Okay. Degeneration of stratum basale is seen in lichen planus. Thickening of stratum granulosum is called hypergranulosis. Thickening of stratum corneum is called hyperkeratosis. Persistence of nucleus in stratum corneum layer is parakeratosis. As we have studied, stratum corneum layer should not have nucleus. Nucleus dead cell should be there. Normally, in nucleus are dead in stratum corneum layer. Nucleus of the cells are dead in stratum corneum layer. But if the nucleus persists, then the condition is called parakeratosis. Okay. So next question: skin turnover time in case of psoriasis is 2 days, 4 days, 8 days, and 10 days. And the answer will be 4 days. So normally skin turnover from basal cell layer to corneum. From basal cell layer to corneum is 4 to 5 weeks. 4 to 5 weeks. That means just over 1 month. Just over 1 month. But in case of psoriasis, what happens? The mitotic activity is increased, and this life cycle of the skin cells, epidermis, from the basal layer to corneum, it does not take 4 to 5 weeks. It turnover time get reduced because the mitotic activity get increased. Actually, what happens is that from basal layer, as we know, basal layer is very actively dividing layer. So first the cells start from basal layer, the mitotic division starts from basal layer, then they reach spinosum, granulosum, corneum. So if this mitotic activity, divisions increases, what will happen? The turnover time, this life cycle, the aging will quicken up, and it will be reduced to 3 to 7 days with the average of 4 days. This typical pathology, this typical abnormality is found in psoriasis, along with other features that we will go afterwards. Okay, so next question: a person starts to sweat on forehead and gets a running watery nose whenever he eats. hot and spicy meals. This kind of sweating is mental sweating, physical sweating, thermogenic sweating, and gustatory sweating. So answer will be gustatory sweating. So what are the types of sweating are there? Gustatory sweating, it occurs on the scalp, forehead, nose, and in response to hot and spicy meals. Hot and spicy meals. This is next. Mental sweating is response to emotional stimuli like mental stress, emotional stress. Sweating usually noticed on the palms, soles, and axilla. Next, thermogenic sweating, sweating in response to preoptic stimulation of hypothalamus in order to maintain the body temperature. Okay, so these are the types of sweating. Next, true about Fordyce spot. Axilla is the most common site. Lips are most common site. These are of eccrine gland ducts. This Fordyce spot belongs to eccrine gland ducts, and blockage of apocrine gland ducts. No, it will be blockage. Blockage of eccrine blockage. It will be blockage of eccrine gland duct and blockage of apocrine gland duct. So true about Fordyce spot is leaves at the common site. So first of all, ectopic Fordyce spots are ectopic sebaceous glands. Ectopic sebaceous glands, which is characterized by discrete pin-headed size, yellowish maculopapular lesion in mucous membrane of lips and oral cavity. Most common site is lips, oral mucosa, vulva, and penis. And most common age group is puberty, and in males it is more probable in males. It mimics or very often confused as Koplik spot of measles, which is we have to differentiate, not Koplik spot. Obstruction of eccrine gland ducts. Then obstruction of eccrine gland ducts occurs in miliaria, and obstruction of apocrine gland ducts occurs in Fox Fordyce's spot disease, also known as apocrine miliaria. And most common site of Fox Fordyce's spot, this is different, not Fordyce spot. Fox Fordyce's spot is most common site is axilla, and this only Fordyce spot most common site is lips, oral mucosa, vulva, and penis also, but then also lips are the most common site. Most common age group of Fox Fordyce spot is 13 to 35 years, and females are most commonly affected. While only Fordyce spots, most commonly age groups affected is puberty, and males are most commonly affected. While in case of Fox Fordyce spot, females are most commonly affected. So difference between Fordyce spot and Fox Fordyce spot. Okay, next question. Which one of the following statements is false? Macule is flat discoloration of less than 2 cm in diameter. Papule is a solid lesion less than 1 cm in diameter. Bulla is a solid lesions more than 0.5 cm in diameter. Vesicles are fluid-filled lesions less than 0.5 cm in diameter. And the answer will be bulla is a solid lesion more than 0.5 cm in diameter. So this is the false. This is the false. So now we will go through, we will revise once the primary lesions in dermatology. So first of all, macule. Macule is a flat colored lesions less than 2 cm in diameter, not raised, very important point, not raised above the surface of the skin. And epithelid, there is another thing is epithelid, which is a prototypical pigmented macule. So macule is a discoloration of less than 2 cm in diameter, which is not raised. Two things. One is change in coloration or discoloration, simply we can call discoloration, or we can get a solid lesion. Solid lesion We can get another thing is that growth. Another thing is growth, and another thing is that fluid field. Fluid field. So mainly we can see all these primary lesions can be classified as this. So macule belongs to this discoloration. So there will be no solid lesion. There will be no growth. Growth is more bigger. Like discoloration is discoloration. Discoloration is other colors, patches, patches. This is discoloration. Solid lesions means solid lesions like this. Solid lesions. Then growth. Growth means growth can be this. This is extra growth. And fluid filled means it will be filled with fluid. This is fluid filled. So different lesions you need to know. So that this is macule. This is patch macule. Now this macule actually becomes, if it becomes, macule is smaller patch, less than 2 centimeter. Less than 2 centimeter. But if this size becomes more than 2 centimeter, simply it becomes patch. With a color of different from the surrounding skin, differs from a macule only in size. That's it. So this is patch is nothing but bigger macule, or macule is alternatively macule is nothing but smaller patch. That's it. So this is about macule and patch. And next, papule. Papule is a small solid lesion less than 0.5 centimeter in diameter raised above the surface of the surrounding skin. So this is solid lesions, small solid lesions less than 0.5 centimeter in diameter, and it's raised above the surface. So papule is now first. Papule comes this is solid lesions. Next, nodule. Nodule is more than 0.5 centimeter, more than 0.5 centimeter, but it mostly becomes mostly it is less than 5 centimeter, more than 0.5 to 5 centimeter, and it is a firm lesion raised above the surface of the surrounding skin, and it differs from papule only in size. Only in size. This is papule is less than 0.5 while nodule is more than 0.5. But nodule will not be more than 5 centimeter, because if it is more than 5 centimeter, this is, for example, this can be nodule. This can be nodule. So this lesion, firm raised lesion, becomes, if it becomes more bigger, then it becomes what? Then it becomes tumor. Solid raised growth more than 5 centimeter in diameter, it becomes tumor. So very important. These sizes are very important, and the whether it is only discoloration or solid body, or solid body actually becomes growth if it becomes more than 5 centimeter. So solid body, solid lesion means two types. If it is smaller, solid lesions if it is smaller than 0.5 centimeter, 0.5 centimeter, that means papule. If it is bigger, then more than 0.5 centimeter but less than 5 centimeter, that is solid body, solid lesion. That is solid lesion. If this solid lesion becomes more than 5 centimeter, then it becomes growth, which is tumor, which we call tumor. Next, plaque. Plaque is a large, more than 1 centimeter but flat top. It has a typical appearance, flat topped raised lesion. Like this, flat topped, raised, but top is flat. It's not hemispherical or like sphere type of shaped. It has flat top. Top will be flat. Edges may either be distinct, like in psoriasis. Edges are distinct. You can literally tell yeah, this lesion has started from this side, and sometimes it blends with the skin, like in eczematous dermatitis. It blends with the skin. Next is vesicle, a small fluid lesion. Next, fluid filled lesion started. First is vesicle fluid lesion raised above the plane of surrounding skin. Fluid is often visible and the lesions are translucent. Vesicle in allergic contact dermatitis is caused by tox toxicodendron. Toxicodendron. Toxic odendron, okay, caused by toxic collodendron or poison ivy. Allergic contact dermatitis. It is one of the important etiology causes. So fluid is often visible because the lesion is translucent. Lesion is translucent. Now this comes to size 0.5 centimeter in diameter, less than 0.5 centimeter in diameter, 0.5 centimeter, and plaque is more than 1 centimeter, more than 1 centimeter. Next, pustule, a vesicle filled with leukocytes. Presence of pustules does not necessarily signify the existence of an infection. Vesicles filled with leukocytes, but that doesn't mean there is infection. That is only pustules. So there is no size in the definitions, but the feature is it is filled with leukocytes. This is the feature of pustule. Next, bulla fluid filled lesion. Also, it is also translucent, but more than 0.5 in diameter, 0.5 centimeter. So vesicle is less than 0.5 centimeter. Features of vesicles are quite similar in bulla, only more than 5 centimeter, more than 0.5 centimeter. Next, wheel, a raised edematous papule of plaque, papule, not papule of plaque, papule or plaque. So in wheel, what is a wheel? A raised edematous means reddish fluid filled. Papule or plaque, usually representing short-lived vasodilatation and vasopermeability. We get it in allergic reactions, allergic hypersensitivity reactions. Next is telangiectasia, not galactasia, telangiectasia. Telangiectasia is a dilated superficial blood vessel. Dilated superficial blood vessel is telangiectasia. There will be reddish. There will be erythematous skin will be reddened. So because of dilation, there will be increased blood flow. Okay, that is telangiectasia. So these are some primary skin lesions. Primary skin lesions. We will also see primary skin lesions in picture and in schematic pictures. Okay, as it is shown in the primary lesions, you see macule. First of all, macule is what? Macule is a flat colored lesion. Flat colored lesions less than 2 centimeter. Less than 2 centimeter. So flat area of color change, no elevations or depressions. Like it's freckles like this. Only discoloration. Papule less than 0.5 centimeter. Less than 0.5 centimeter. Solid elevations. Nodules like allergic eczema, like allergic eczema. Nodules, solid elevations 0.5 to 1 centimeter in diameter, extends deeper into dermis than papule nodules. So 0.5 to 1 centimeter. You see the nodules 0.5 to 1 centimeter in diameter, but up to 5 centimeter it can go. Okay, 0.5 to up to 5 centimeter it can go. actually. So 0.5 to 5 centimeter actually. And example is mole. Okay, next tumor larger than 5 centimeter. Larger than 5 centimeter. Example squamous cell carcinoma. Plaque is flat elevated surface found in on skin or mucous membrane. Wheel is types of plaque, result is transient edema in dermis, like intradermal skin test is done, then wheel is shown. Okay, that is wheel. Vesicles, small blisters, bulla, large blisters, pustules, vesicles filled with pus. So as these are all primary lesions, and secondary lesions includes scales, crust, fissures, scales like flakes of cornified skin layer, flakes of skin of the skin like psoriasis, because the turnover time is increased. Sorry, turnover time is decreased. Mitotic activity is increased. Mitotic activity is increased. So turnover time is decreased to average 4 days. And crust is dried exudate on skin. Fissures are the cracks in the skin. Cracks in the skin, like athlete's foots you can see. Next we know ulceration, area of destruction of entire epidermis. Ulceration, skin ulceration. This is about skin ulceration, which is seen in like bits, like pressure sore, in decubitus position. Patient in decubitus position for long time can for them it can occur. Then we got scar. Scar is excess collagen production after injury. Scar. Loss of some portion of the skin is called atrophy, like paralysis. Okay, these are some real pictures. Nodules, cyst, bully, macule, plaque, wheal, vesicle, pustules. There's some real pictures for IBQ. Nowadays, IBQ comes, image-based questions comes in dermatology. So it can be asked, what is this? Simply very direct questions also comes and cases also comes. So they can ask, what is this lesions? Bully, cyst, nodules, macules. And another thing is very advisable is that you need to see different kinds of photos of only one thing. Like this picture is given for bully. It's okay, fine, but you need to see more pictures of bully, because they give different pictures. Just remembering or practicing on one picture is not enough, because it will change in the exam. It will change in the exam, and that is why you need to go through more pictures from the internet or anywhere. We also we will give you online exams also. There also you will get more pictures. Okay, so these are some pictures of macules, papule, wheal, vesicles, and pustules. Okay, next question. A papule that is raised non-purulent is most probably due to insect bite, urticaria, angioedema, erythema nodosum, and the answer will be insect bite. Papule, raised papule, non-purulent papule. Presence as papule is insect bite. In insect bite, the lesions presented as papule. It can be painful or can be painless. Angioedema is edema of subcutaneous or submucosal tissue, which can be due to allergic reaction like this. This is angioedema. Urticaria is autoinflammatory conditions. Most commonly symptom is itching. This is urticaria. Next, erythema nodosum, inflammation of submucosal fatty cells. Erythema nodosum. This is erythema nodosum, and it appears as like nodes. That's why the word nodosum. Inflammation of submucosal fatty cells. Green color at bruise site is due to hemotidine, bilirubin, hemosiderin, biliverdin. We have already done this question actually in forensic, but for dermatology also it's very important. is biliverdin, and we have seen this table also in the forensic. Like green color at bruise side, how a bruise heals. First at day 0, it will be hemoglobin. It will be reddened. It will be red colored. That's why because of hemoglobin, because of fresh blood, accumulation of fresh blood. Next, it becomes blue colored in next day, day 1. Day 0 is the occurrence, day of occurrence. Bruise occurred here. Next, first day is deoxygenated hemoglobin. Because the hemoglobin will not be recycled, it will be blue colored. Next 2 to 4 days, after 2 to 4 days, bluish black and dark blue to brown color, and due to the accumulation of hemosiderin. And green color will come 5 to 7 days. After 5 to 7 days, due to biliverdin hematoidin. And bilirubin, when bilirubin will come after 7 to 10 days of the bruise, from the day of occurrence, and it will be yellow colored. And normal colored within 2 weeks, not just within equal to 2 weeks, that is 14 to 15 days, pigment removed by phagocytes, and the normal color of the skin will be recovered, will be replaced. Okay. So bruise is a skin contusion, which is also known as hematoma of skin. Hematoma of skin. And that is why there will be accumulation of hemoglobin or blood, accumulation of hemoglobin or blood. Okay. So capillaries and sometimes venules are damaged by trauma. Due to trauma, what happens? The capillaries in the skin and sometimes the venules as well, they get damaged. And due to this, resulting the blood to seep out, to come out. That is called hemorrhage or extravasate into the surrounding interstitial tissues. And in this way, there will be accumulation. And larger bruise may change the color due to breakdown of the hemoglobin from within the escaped RBC in extracellular space. And the striking colors of the bruise are caused by phagocytosis, sequential degradation of hemoglobin that we just studied, sequential degradations to biliverdin, to bilirubin, and to hemosiderin. The color changes noted at the site of bruise. The color changes noted at the site of bruise is secondary to hemoglobin itself producing a red-blue color, then biliverdin producing a green color, yellow color is produced by bilirubin, while golden brown color will be produced by hemosiderin, golden brown color. So this color changes with the accumulations, are very important. And for forensic medicine subject, duration is important, very much. This duration is important overall. That's why I have given this table in this slide, because whole table needs to be learned for FMG, whole table. And for IBQ also, forensic medicine also, this picture is important. This picture is important. Even they can give a clear-cut picture of bruise and can ask you in which how many days. If it is forensic science, then they can give forensic medicine. Then they can give how many days it has been already. Like they can give a bruise healing picture, healing of a bruise, and if you can see it's greenish already, then the duration will be 5 to 7 days. Or if it is yellow, then 7 to 10 days. So in this way. So whole table is very important for FMG. Anyway, next question. Acantholysis and intraepidermal blisters are found in dermatitis herpetiformis, pemphigus vulgaris, eczema, bullous pemphigoid. Acantholysis and intraepidermal blisters. Acantholysis and intraepidermal blisters are found in dermatitis herpetiformis, pemphigus vulgaris, eczema, bullous pemphigoid. The answer will be pemphigus vulgaris. Pemphigus vulgaris. So, about pemphigus, first of all, pemphigus is an autoimmune blistering disorder. Autoimmune blistering disorder, you need to remember this, autoimmune. So, pemphigus vulgaris, the first point is autoimmune. results from loss of integrity of normal intercellular attachments with the epidermis. Intercellular attachments with the epidermis commonly affects individuals of age between 40 to 60 years. So the age predisposition is 40 to 60 years, and the loss of integrity of normal intercellular attachment with the epidermis. So what happens? The pathology inside. The pathology is loss of normal intercellular attachment, loss of integrity of normal intercellular attachment, intercellular attachments with epidermis. Epidermis. This is the pathology. Commonly affects the individual of 40 to 60 years old, and equal prevalence. Male is to female, 1:1. Equal prevalence, 1:1. So there are 5 variants of pemphigus. Vulgaris is the most common type. Foliaceous is superficial pemphigus. Vegetans least common type. Pemphigus erythematous. Fogo is endemic form of pemphigus foliaceous. So vulgaris is most common type. Foliaceous, superficial pemphigus. Vegetans least common type, and erythematous main 4. And another variant is Fogo selvagem. It's an endemic form of pemphigus foliaceous. So rounded keratinocytes with hyperchromatic nuclear found, very important. Other than picture, you also need to remember the descriptions of the lesions. The description of the lesions, because although IBQ comes nowadays, but descriptive questions have not recited, are also coming. Okay. So that's why the description of the lesions are also very, very important. First, the description is important, and along with that, IBQ is also important. So the rounded keratinocytes with hyperchromatic nuclei and perinuclei halo, that is due to condensing of cytoplasm in periphery, are called acantholytic cells. What are acantholytic cells? So the rounded keratinocytes with hyperchromatic nuclei and perinuclear halo. It is seen in the case of pemphigus vulgaris. An acantholytic cell can be demonstrated by bedside junk test. Very important. Acantholytic cells are diagnosed by bedside junk test. Okay. So pemphigus vulgaris as a thin-walled, delicate, flaccid bully blisters occurs here in this disease that rapidly ruptures and also erodes. So bulla or blisters, we can say. Upper part of the body, buccal mucosa is commonly involved. Upper part of the body or buccal mucosa. Acantholysis, some of the features of pemphigus vulgaris is acantholysis, Nikolsky sign, row of tombstone appearance, and lesion biopsy is done. Biopsy of the lesions is done, and acantholysis, intraepidermal blisters are found. IgG positive, complement deposition occurs between epidermal cells, and for as part of the management, systemic steroid and immunosuppressants are given. As we know, it is an autoimmune disorder, we go for immunosuppressant. Okay, next. Various signs seen in atopic dermatitis, pemphigus vulgaris, urticaria pigmentosa, bullous pemphigoid. Various signs seen in urticaria pigmentosa. Urticaria pigmentosa. Now, so when a urticaria pigmentosa or mastocytoma lesion is stroked, it typically articulates, becoming pruritic, means itchy, edematous, erythematous. So pruritic means itchy, edematous means submucosal fluid accumulation, erythematous means red colored. So this change is referred to as Darius sign. This change is referred to as Darius sign, explainable on the basis of mast cell degranulations. That means typical allergy, right, induced by physical stimulation. So physical stimulation like touching of any object or like that, will activates Darier's signs. Okay, and Darier's sign is composed. It means there will be pruritus, means itching, plus edematous, submucosal fluid accumulation, plus erythematous. That means red colored skin. Erythematous. Red colored skin, it is actually attributed to the increased blood flow. Because mast cell degranulation is occurring. That means histamine induced reaction will occur. Will present histamine induced. Okay, and histamine increase, and like there will be acute allergic reaction. So excess of mast cell in many tissues lead to numerous red, brown, pink papules over the trunk or limbs. Present as red and pink nodules in infants, in young children, but disappear later in childhood. This is urticaria pigmentosa. Atopic dermatitis, which is characterized by white dermatographism. That means if we can also white dermatographism means we can literally draw lines on the skin with any blunt object. When our skin becomes quite dried, then we can draw something on the skin with our nails or like anything blunt or sharp object. Not as sharp as knife, but with like with nails and all, we can draw white lines. That is called dermatographism. So in atopic dermatitis, it will be exaggerated. You can draw very minute lines on the skin of the patients. So in atopic dermatitis, this is even the doctors use the diagnostic features by drawing white line on the skin of the patients, skin of the hands of the patient. So if it can be drawn, very minute lines can be drawn, then atopic dermatitis can be confirmed. Is one of the quickest way to diagnose. Pemphigus vulgaris. It's a manual pressure on the skin elicits the separation of epidermis. It is called Nikolsky sign. And bullous pemphigoid is characterized by urticarial eczematous prodrome with faint dusky erythema. In figurative pattern, Nikolsky sign, row of tombstone appearance, and bulla are seen in bullous pemphigoid. Okay, all are true about Xeroderma pigmentosa except due to deficiency of zinc, marked sensitivity to UV light due to defective DNA repair, and autosomal recessive. So which one of this is false about Xeroderma pigmentosa? And the answer will be due to deficiency of zinc. So disease entity which is caused due to deficiency of zinc is ectodermatitis enteropathica. This is caused due to deficiency of zinc. Okay, not Xeroderma pigmentosa. Xeroderma pigmentosa is basically an autosomal recessive skin disorder with cellular hypersensitivity to UV radiations and certain chemical agents as well as cancer chemotherapy agents like cisplatin and carmustine. Covalent linkage between Adjacent pyrimidine. Adjacent pyrimidine in DNA is damaged by UV rays chemicals. In normal circumstances, what happened? Damaged DNA is repaired by nucleotide excision repair pathway. But in case of xeroderma pigmentosa, this nucleotide excision repair pathway get damaged. It get defective, or we can say defective. So if the repairman gets defective, then obviously it cannot repair the DNA. It cannot repair the damaged DNA. That is why in xeroderma pigmentosa, this DNA is not repaired. And the clinical features includes in xeroderma pigmentosa, hallmark is photosensitivity. Hallmark is photosensitivity causing acute sunburn reaction on minimal UV exposure. This is the biggest thing. This is the biggest characteristics. That hypersensitivity to UV radiations. Hypersensitivity. Obviously, sun contains ultraviolet radiations, but our skin is well adapted to protect us from these ultraviolet radiations. But due to damage in the DNA, which cannot be repaired because the repair pathway is itself damaged. That's why the damaged DNA cannot be repaired. The skin cannot protect the beneath layer of the skin from UV radiation, and resulting in pigmentations, giving the name xeroderma pigmentosa. Gives the name xeroderma pigmentosa. So ocular involvement also occurs. Loss of eyelashes, conjunctival infections, keratitis and keratitis. So these are some of the eye involvement. And neurological involvement, mild cases hyporeflexia, severe cases mental retardation, sensorineural deafness and spasticity, and seizures. These are 4 characteristics that can be seen in severe cases: mental retardation, sensorineural deafness, spasticity and seizures. And in mild cases, hyporeflexia. So these are the characteristics, clinical presentation of XP or xeroderma pigmentosa. Next, acrodermatitis enteropathica is due to the deficiency of, as we have done just in the previous slide, that is zinc, characterized by abnormalities in zinc absorption. Abnormalities in zinc absorption due to defect in intestinal zinc transporter, leading to the zinc deficiency. It's a rare autosomal recessive disorders classically present during infancy and weaning from breast milk to formula or cereal, which have lower zinc bioavailability than breast milk. So rare autosomal recessive disorder classically present during infancy on weaning from breast milk to formula milk, which have lower zinc bioavailability than breast milk. Okay, when from exclusive breastfeeding to infants are taken to formula or cereals after 6 months of exclusive breast milk feed, then they may show this disorder, acrodermatitis enteropathica, because in formula milk or cereal, zinc is less. And due to the abnormalities in zinc absorption due to defect in intestinal zinc transporter in GIT, intestinal zinc transporter, already this formula and cereal have low zinc availability, and due to this intestinal zinc transporter defect, the effective zinc availability is very less, and it's very less, leading to the clinical features like diarrhea, depressions, eczematous erosive dermatitis, alopecia, non-scarring alopecia, apathetic look, lethargy, irritability, and crying. Okay, so these are the features that occurs due to the deficiency of zinc in acrodermatitis enteropathica. All are true about keloid except maybe familiar, appears mostly on sternum, subsides over time, hyperkeratotic. So all are true about keloid. So which one of this is false about keloid? False about keloid is subsides over time. Okay, so the false about keloid. So first of all, it is familial, familial, and appears mostly on sternum and hyperkeratotic. So what is keloid? Keloid is nothing but their scars which does not stop growing. This is the typical keloid that we can see. We know if there is a cut, maybe any wound, maybe surgical, maybe trauma due to trauma. Okay, if there is a wound, there will be scarring. There will be scarring to join that wound, and the scarring should be here within the to join the two ends of the wound. To join the two ends of the wound. Sometimes, if the wound is big enough, sometimes a line or patch remains for lifetime. In many people, you can see lifetime wound scar is present, but especially surgical scar is quite prevalent. But in case of keloid, this scarring is not only bound to this region, but also they grow. They grow. They grow and do not stop, and it becomes bigger in size. It becomes bigger in size, and they do not subside. Do not subside over the time. Instead, they spread and includes the normal skin also. They affect the normal skin also. You see, obviously the cut or the wound is not so bigger. It invaded, and it's so deep, it's so thick. They are made up of dense collagen fiber because they are made up of dense collagen fibers. It can appear few days to few weeks after surgery also in case of surgical wound. Usually has a smooth top and pink or purple colored, irregularly shaped. There is no shape. There is no defined shape, irregular shaped, tend to enlarge progressively. And another thing is that recurrence is possible after local excision. If simply excision is done, it can reoccur. Okay, recurrence is possible. Is familial, runs in family. Most common site of keloid. Most common site of keloid is in sternum. It can be treated by intrakeloid injection of triamcinolone. Best cure of keloid is achieved by excision and radiotherapy. So first of all, what are the management procedures of keloid? Intrakeloid inside the keloid, we can give triamcinolone. Another thing is that best management procedure is excision plus radiotherapy, RT. This is the best one. This is the best one. Okay, so this is about keloid. Next, dermatophytes are tinea versicolor, dermatophytes are tinea versicolor, trichophyton rubrum, sporothrix, all of the above. Dermatites are tinea versicolor, trichophyton rubrum, sporothrix, and all of the above. And the answer will be trichophyton rubrum. Dermatophytosis or ringworm, they include a group of fungi which under most conditions have the ability to infect, survive only on dead keratin. So they survive, dermatophytes, these fungi, these are fungi, right? Phytes, so this suffix phytes. Okay, so these are fungi, survive dead keratin. Dead keratin. Dead keratin. So that is superficial topmost layer of the skin. Dead keratin to superficial topmost layer of the skin. In fact, as we have already studied, this dead keratin, this here the dermatophytes survive. Here the dermatophytes survive. It can be said as that dead keratins stay above stratum corneum because they do not stay. Basically, they falls off. As we have studied, they falls off, right? So stratum corneum is the first layer, most superficial layer. But above so corneum also we have dead cells. So the topmost layer of the skin, that is stratum corneum or the keratin layer. So first of all, topmost layer of the skin, it may be then nails also. So dead keratin super. So it survives on the topmost layer of the skin, that is corneum, or the above the corneum, or hair, or nails. Topmost layer of the hair, topmost layer of the nails. They cannot survive on mucosal surface like mouth or vagina, where the keratin layer is absent. They need keratin. That is the point. They need keratins. So three genera of fungi are there: Trichophyton, Microsporum, Epidermophyton. Trichophyton, they infect skin, hair, nail. They infect skin, hair, nail. Skin, hair, nail. And infecting species include Trichophyton rubrum, Mentagrophyte, Violaceium, Verrucosum, Squalene. So this is important, Trichophyton rubrum. Next, Microsporum infects skin and hair, but not nails. Several infecting species include Microsporum, Gypsium, and Canis. Epidermophyton infects skin and nails, but does not involve hair. does not involve hair. Only infecting species is epidermophyton flocosum. So does not involve hair, skin and nails. So this is very, very important. Trichophyton, skin, hair. Trichophyton, skin, hair, nail. Hair, skin and hair. Microsporum, skin, hair. And epidermophyton, skin and nails. Okay. So either the positive, in a positive way, you need to remember, like trichophyton, skin, hair, nails, microsporum, skin, hair, and epidermophyton, skin, nail. Or in negative sense, in negative way, you can remember trichophyton. In trichophyton, these dermatophytes can infect all the things like skin, hair, nails. Microsporum only nails is not, nails are not involved, and epidermophyton only hairs are not involved. So in this way you can also remember according to your convenience. Okay, so this is very important, and this feature is very important, much more important than the infecting species. This feature is very important. Okay. Okay, next question. A case of 12 years old boy presents with boggy soiling and easily pluckable hair. With swelling and pluckable hair, what would be the probable diagnosis? Lichen planus, tinea capitis, epidermophytosis, alopecia areata. And the answer will be tinea capitis. Is the most commonly caused by Microsporum canis. First of all. Secondly, most common cause of tinea capitis is Trichophyton tonsurans. Second most common cause. Most common cause is Microsporum canis. This is only very important. Okay. Otherwise, Trichophyton tonsurans, never caused by epidermophyton, as it does not involve hair. Does not involve hair. Epidermophyton does not involve hair, right? Does not involve hair. It presents with localized non-cicatrical alopecia. Localized non-cicatrical alopecia, itching, scaling with or without boggy swelling of scalp, and easily pluckable hair. Tinea capitis diagnosed by potassium hydroxic wet mounts of hair scale. And treatment is grisofulvin, is the DOC, grisofulvin. Do remember, tinea capitis, grisofulvin is the DOC. Diagnosed by KOH wet mount. KOH wet mount. Okay. And the IBQ is very important. IBQ is very important. Age is important. And the features, swelling and pluckable hair, is also important. So you need to correlate when the question and cases will come. Cases mostly comes like this 1 line, 2 line cases, mostly from dermatology. Okay. So next, an adult male presented 4 weeks after intercourse with fever, rubbery ulcer, inguinal lymphadenopathy. Causative organism is LGV, syphilis, cancroid, HIV. And the answer will be LGV. Lymphogranuloma venereum. So very important is intercourse. After 4 weeks after intercourse. Then the features: fever, ulcer, rubbery ulcer, inguinal lymphadenopathy. Very important, lymphadenopathy. Lymphogranuloma venereum is a STD. It is caused by chlamydia. Painless lymphadenopathy occurs. Painless lymphadenopathy. This disease occurs due to the infection of L1, L2, and or L3 serovars of Chlamydia trachomatis, right? Chlamydia trachomatis. The causative organism is very important also. And painless lymphadenopathy. The question comes, which one of these following is painless in lymphadenopathy? LGV is painless lymphadenopathy. Very important. And some of the characteristic feature of LGV is number 1 is bubo. Number 2 is positive group sign. Positive group sign. Another is phrase test is there. Number 3, but it's not so important because nowadays it's not used. But first of all, bubo. What is bubo? We'll see. Bubo is an inflamed swelling inside a lymph node characteristic of second stage LGV. Inflamed swelling inside a lymph node. Inflamed swelling inside a characteristic of second stage. This. Next, group sign. Large, hard, fixed, extremely tender lymph nodes in the groin above and below the inguinal ligament with a groove along with the ligament. Characteristic of LGV. Characteristic feature of LGV. Very, very important group sign. Tender lymph node in the groin above and below the inguinal ligament. So above the groin, lymph nodes in the groin above and below the inguinal ligament. Below the inguinal ligament. That means inguinal ligament, then tender lymph node, and the above is groin, above the groin. So above the groin, below the inguinal lymph node, this lymph node will be inguinal ligament. This lymph node will be situated between inguinal ligament and groin with a groove along the ligament. So this is characteristic feature of LGV group sign. Another thing is phrase test. It's an obsolete test for LGV in which intradermal inoculation of LGV infected yolk sac is used to detect a delayed type of hypersensitivity reaction. Delayed type of hypersensitivity reaction, type 3. Type 3. So delayed type of hypersensitivity reaction. Okay, so this is an obsolete test. What is used? Intradermal inoculation of LGV infected yolk sac. Okay, so is used to detect a delayed type of hypersensitivity reaction. Not type 3, type 4. Okay, type 4. Cell mediated. Type 3 is immune complex mediated. So this is LGV phrase test. Phrase test nowadays is obsolete. But important is group sign and bubo. These are important. Very much. Bubo and group sign, especially bubo and also group sign, also characteristic feature of LGV. Another thing is one of the some clues in the case can be there like 4 weeks after the intercourse. So you can understand some STD, but syphilis, HIV, all these are also can be characterized classified as STD. And ulcer is there, fever, ulcer, lymphadenopathy. So this is very important. And the IBQ. For IBQ, this bubo can be there, bubo. Okay. So anyway, next question. Painful ulcer on glans penis is seen in syphilis, LGV, chancroid, and Sankar. Chancroid and Sankar, LGV, syphilis. The painful ulcer on glans penis, chancroid. Painful ulcer on glans penis, chancroid. This is chancroid. Chancroid. So chancroid is a bacterial STD caused by Haemophilus ducreyi, which is characterized by painful sores on genitalia. Painful sores on genitalia. Painful sores on genitalia. This. These are all painful sores on genitalia. And on the other hand, Sankar, on the other hand, is a painless ulceration sore most commonly formed during the primary stage of syphilis. Sankar is the lesion, the characteristic lesion of syphilis. That is very much well known. Syphilis, always remember Sankar. This. Painless ulceration, painless ulceration. This is painless condition, painless lesion. While in chancroid, it is painful ulcer, and it is on the glans penis. It is on the glans penis. For example, see here it is glans penis. The glans penis. Okay, so chancroid is known to spread from one individual to another solely through sexual contact. Solely through sexual contact. Okay, and Sankar is different. Sankar is different, and it can be present other than it's not in the glans penis or not on the genitalia, not on the genitalia, not on the genitalia. They will be in the around the genitalia, around the surrounding the genitalia, places around the genitalia, and the source are looks also different. Okay, so Sankar looks like this. This is Sankar in syphilis. Okay. Okay, so the stages of syphilis are very important for the primary Sankar lesion is the hallmark of primary syphilis. Okay, it may appear 10 to 90 days after the exposure. Common sites include penis and labia. Other sites include anus, oral mucosa also. So Sankar can occur not only but also in labia, anus, oral mucosa, oral mucosa. So this is about Shankar, and without treatment, Shankar disappears in 2 to 8 weeks. Secondary stage of syphilis includes rash, pink to brown macules, involves sperm and cells in 50% of cases, and oral lesions called mucus patches resembling snail track. Snail track appearance. Very important. Snail track appearance. Symptomatically, early neurosyphilis, cranial nerve deficits, and aseptic meningitis presentation is the presentation. This is the second stage. Second stage presentation is symptomatic early neurosyphilis, cranial nerve deficits, and aseptic meningitis. Next, ocular syphilis can occur in the second stage, and manifestation will be uveitis, either anterior or posterior. Next, genito-inguinal rashes can be there, and it can mimic tinea or wart-like lesions, and these are wart-like lesions called condyloma lata. And less common internal organ manifestations like acute hepatitis and nephrotic syndrome can also occur in second stage. So primary stage is characterized by Sankar that can be found in penis, labia, anus, oral mucosa, and also places around these. An exposure and Sankar comes after 10 to 90 days 10 to 90 days after the exposure. And Sankar disappears within 2 to 8 weeks. That is primary stage of syphilis. Secondary stage of syphilis, there will be rash, pink to brown macules. Rash, pink to brown macules. Next, oral lesion, mucus patches resembling snail tracks. Oral lesions or mucus patches. Next, early neurosyphilis, cranial nerve deficit, and aseptic meningitis. Neurosyphilis, cranial nerve deficit, and aseptic meningitis. Ocular syphilis, if ocular manifestation occurs, then uveitis. It can be anterior uveitis or posterior. Next, condyloma lata, genito-inguinal rashes, including which includes tinea, mimicking tinea, rashes that mimics tinea or what-like lesions, condyloma lata. Next, less common internal organ manifestation occurs, but if occurs, then acute hepatitis and nephrotic syndrome. This is secondary stage of syphilis. Latent syphilis refers to asymptomatic infections after the period of primary and secondary syphilis. So that is latent. It can be divided into early latent and late latent also. And tertiary stage characterized by neurosyphilis, including tabes dorsalis, gait impairments. So tabes dorsalis, gait impairments, dementia, tabes dorsalis damages the dorsal columns and sensory nerve roots, causing a syndrome of pain and sensory deficits similar to those of B12 deficiency. Okay. Next, gumma formation, very important and very characteristic. Gumma formation. Gumma are ulcerating granulomas on skin, bone, and internal organs. So ulcerating granuloma. Cardiovascular manifestations like late stage includes aortic aneurysm and coronary arteritis. So these are the stages of syphilis. Very important, syphilis, very important for dermatology. First few years, there will be no signs or symptoms. First stage is the sore or the chancre found in genital area, inner part of the vagina in women in case of women, and penis in case of men. Other areas are anus and oral mucosa. Then chancres do not result in pain. They are painless. That is another, actually it leads to more problem and dead detection. Do not result in pain. Disappear without treatments. So the probability of overlooking the patient is quite high. Next, stage 2, skin rash, macules, red, reddish, brown spots on palms and hands and bottoms and feet. These are the sites. Then mucous membrane lesions throughout the body without itchiness. There will be no itchiness. There can be fever, sore throat, headache, swollen gland, weight loss, muscle ache, fatigue in second stage. In the third stage, blood vessels, cardiac involvement, nerve system, neural involvements starts. Like neurosyphilis occurs, those are called neurosyphilis, including tabes tabes dorsalis, damaging of internal organs. In fact, death may occur in the third stage. And in latent stage, symptoms disappear for 1 to 20 years. Diagnosis through blood testing only, and relapse may occur. Latent stage. It may persist. If syphilis persists, that it may stay in latent stage. It can be further divided into early latent stage and late latent stage also. And another thing is that in the late stage, we see tabes dorsalis, gait impairment, dementia, guma formations. While uveitis, neurosyphilis, rashes, and snail track oral mucosal lesions are found in secondary ones. And Sankar is the primary. Lesions are primary stage. Okay. Guma is ulcerating granuloma. So this is all about syphilis. Very, very important topic for FMGE. Next question, school of fish appearance is seen in bacterial vaginosis, Haemophilus ducreyi, Gonococcus chlamydia. So the answer will be Haemophilus ducreyi. So school of fish appearance. This is school of fish appearance. Stain smear from genital lesions in case of chancroid. Causative agent of chancroid is H. ducreyi, as we have already studied, which is a major cause of genital ulceration in developing countries characterized by painful sores, right? Painful sores, but in syphilis, no pain, painless. Sankar is painless, but chancroid is painful. Both are on the genitalia, but you know, these ducreyi means chancroid. Chancroids are on the maybe on the glans penis. Okay, on the glans penis, and Sankar can be on glans penis and mainly on the genitalia. But Sankar can, on the other hand, is painless, and other than in the pain on the penis, it can be seen in anus also, and also in the oral mucosa. Okay, regarding coming back to chancroid, it is another early symptom is dark or light green shears excrement is seen, and it starts as an erythematous papular lesion, breaks down into painful bleeding ulcer. So in chancroid, painful bleeding ulcer, very, very important, bleeding ulcer, and obviously painful, with a necrotic base and rugged edges. It can be cultured on chocolate agar. And this school of fish appearance. This is a typical histologic appearance arranged in parallel chains of 2 or 4. This you see pleomorphic gram-negative coccobacilli, that is Haemophilus ducreyi. Okay, this is Haemophilus ducreyi. Gram staining, gram negative. So you see they are like school of fish, like fish while swimming, they swim like in a bunch together, in a arranged in line. Okay, this line can be bigger also. Minimum of 2 to 4 this bacilli should be there to be called as school of fish appearance. School of fish appearance. Minimum of 2 to 4. Like here you see, these are 3. Here you see many. They are arranged line by line. Okay, this is school of fish appearance. All cause genital ulcer except All cause genital ulcer except gonorrhea, chancroid, HSV, herpes simplex, and lymphogranuloma venereum. So the answer will be except gonorrhea, because already we have studied these three, no, chancroid and LGV. Both of them we have seen genital ulcer is present. So gonorrhea is a STD caused by N gonorrhea, that is Neisseria gonorrhea, doesn't present with genital ulcer. Very important point, doesn't present with genital ulcer. Patient present with greenish yellow or whitish discharge from vaginal, lower abdominal or pelvic pain, burning sensation when urinating, burning sensation during urination, conjunctivitis, swelling of the vulva, vulvitis, burning in the throat due to oral sex, swollen glands in the throat due to oral sex. All these due to burning in the throat and swollen glands in the throat due to oral sex. So these are features of gonorrhea. A genital ulcer is located on genital area caused by STD like genital herpes, syphilis, chancroid, and chlamydia trachomatis. Genital ulcers are not strictly a sign of STD. They can occur in patients with Behçet syndrome also, lupus also, some form of rheumatoid arthritis also, all non-communicable disease. Behçet syndrome, lupus, some form of rheumatoid arthritis. So presence of genital ulcer doesn't always mean that this is STD. It can be also seen in non-communicable disease. Very, very important point. It is also seen in non-communicable disease like Behçet syndromes, lupus, some form of rheumatoid arthritis. Genital tuberculosis caused by direct genital contact with infected sputum can also present as genital ulcer. Okay, so gonorrheas, these are the features of gonorrhea. The features of gonorrhea. Okay, next question. Child with recurrent mouth ulcer usually begin as round yellowish elevated spot. Round yellowish elevated spot surrounded by red halo and heals within 7 to 10 days. Gingivitis, aphthous ulcer, malignancy, herpetic ulcer. And the answer will be aphthous ulcer. Aphthous ulcer are also called as canker sores or aphthous stomatitis, present as a round ulcer with base and surrounded by red halo. Their usual sites are oral mucosa on the insides of lips, oral mucosa, cheeks or below the tongue. Cheeks or below the tongue. This is the ulcer and this is the red halo. This portion of the red halo. This portion of the red halo. And this is the ulcer. Oral mucosal ulcer, round ulcer. Rather we can say round ulcer. Okay. Most of the aphthous ulcer are less than 5 mm in size. They are mostly 5 mm in size, round ulcer, and heal within 1 to 2 weeks. Painless recurrent aphthous ulcer are seen in SLE. Painful recurrent aphthous ulcers seen in oral cavity, genitalia, and seen in Behçet's disease. So painful recurrent aphthous ulcer in oral cavity and genitalia is seen in Behçet's disease. Painful recurrent aphthous ulcer. Okay. Okay, next question. Alopecia areata is due to defect of this stage of hair growth. Anagen, effluvium, telogen effluvium, catagen, and none. And the answer will be anagen effluvium. So alopecia areata is a is an autoimmune disorder in which anagen is prematurely arrested. It presents as non-inflamed bald patches on scalp. And pathognomic feature is exclamation mark here, taper as they approach the scalp. Exclamation mark here. That means here in this portion the hair will get less, get bald. The scalp will get bald here, and there will be an one circle. So it's like exclamation mark, exclamation mark. Like, so this is called exclamation mark position. Treatment is localized condition steroids, and in extensive condition application of diphencyprone is effective. Diphencyprone. Okay, next is telogen effluvium. Hair follicles are usually not involved in this phase. If synchronized into telogen resting mode, will be shed in about 3 months later and might be seen in severe stress, high fever, childbirth, and surgery. And catagen is a resting phase of hair follicle development. So resting phase, the catagen is the resting phase of hair follicle development and lasts for 3 to 4 weeks. Here protein synthesis stops in this phase, catagen phase, and follicle retreats towards the surface. 10 to 20% scalp hair are in this phase at any given point of time. And telogen effluvium is a hair follicle are usually not involved in this phase, and if synchronized into telogen resting mode, it will be shed in about 3 months later. It might be seen in severe stress, high fever, childbirth, and surgery. Okay, these are the stages of hair growth, phases of hair growth. Very important, simple question comes from this topic in FMG, phases of hair growth. First of all, anagen. Anagen is active growth stage of hair. Active growth stage of hair. Active growth stage. Active stage. During the anagen stage, the hair contains its highest amount of melanin. This stage lasts between 3 to 6 years. 3 to 6 years. Catagen. Catagen is a transitional stage in which the hair stops growing, but the hair is not shed. So catagen is the transition stage. This is the transition stage in which the hair stops growing. Hair stops growing. Stops growing, but the hair is not shed. During this stage, what happens? That follicle is being reabsorbed, and this stage lasts for 2 to 3 weeks. Telogen. Telogen is a resting phase during which the follicle recedes. Hair follicle recedes, and the hair begins to fall in preparation for the development of the new hair. So hair falls. Hair falls. Hair falls in which stage? Telogen phase. 6 to 8 weeks. This stage lasts for 6 to 8 weeks. Duration is 6 to 8 weeks. Next, anagen. The hair growth cycle continues as anagen begins again. The old hair has shed and the new follicle has formed, which begins growing to replace the new replace the hair that was shed. That is anagen. And then anagen again continues as active stage. So in anagen, this stage is included. That means the old hair is shed and the new follicle formed. New follicle is formed. And new hair begins. New hair starts to and it is the most active stage. It is the active stage, and hair contains its highest amount of melanin and lasts for 3 to 6 years. 3 to 6 years. Okay, so these durations and the features, each one of these is very, very important. Infection caused by HPV or human papilloma virus. Condyloma lata, condyloma acuminata, varicose wart, and plantar wart. And the answer will be infection caused by human papilloma virus. Condyloma acuminata. Condyloma acuminata is caused by human papilloma virus. So warts. In common word, we call it warts caused by HPV, most common virus-induced tumor, and shows Koebner's phenomenon. Now, Koebner's phenomenon, what is this? Koebner's phenomenon is the appearance of new skin lesion of pre-existing dermatosis on areas of cutaneous injury in otherwise healthy skin. It is known as Koebner's phenomenon. That means the appearance of new lesion, obviously skin lesions, so new lesions of pre-existing dermatosis, lesions of pre-existing dermatosis on the areas of injury. If there is cutaneous injury, and if there is dermatosis, pre-existing dermatosis, then new lesions come. Appear. New lesions appear. This phenomenon, this occurrence is called Koebner phenomenon. Acuminata, condyloma acuminata are genital warts caused by HPV type 6 and 12. HPV 6 and 11. 6 and 11. HPV 6 and 11. And drug of choice is 20% podophyllene and or glutaraldehyde. Drug of choice dose is 20% podophyllene or glutaraldehyde. And in pregnancy, trichloroacetic acid, TCA, is called TCA. If the patient is a pregnant woman, then we go for TCA. For pregnancy, TCA. And most common wart is varicose vulgaris. There are many types of wart caused by HPV: plain wart, piliform wart, plantar wart, venereal wart, massive wart, condyloma lata. Condyloma Treponema pallidum, seen in Treponema pallidum infection. And venereal wart, condyloma acuminata, venereal wart, this acuminata, HPV 6 and 11. Yeah. Then plantaris or plantaris, varicose plantaris, plantar wart, varicose filiformis, filiform wart, and varicose plana, plain wart. Okay, so these are the warts and seen in which conditions. All of the following tests are used for the diagnosis of leprosy except clinical examination, lepromin test, slit skin smear, and skin biopsy. And the answer will be lepromin test. All of the following tests are used for leprosy except lepromin test. So why? Because lepromin test it tells about cell-mediated immunity and classifies the type of disease. Which type of leprosy? It classifies. Lepromin test tells us which type of leprosy, which types of leprosy has occurred. But no diagnostic value. Very important, no diagnostic value. Diagnosis of leprosy is done by clinical examinations, sensory testing, whether senses are present or absent. Absent, that means positive. Peripheral nerve examination. Demonstration of acid-fast bacilli. This is very important. Like in skin smears prepared by slit scrap method. Scrapping of the skin. Nasal swabs by modified Jeden method, Jeden stain, Jill-Nielsen stain, not Nielsen. Nielsen. Okay. Next, nerve biopsy, foot pad culture in mouse. So demonstration of acid-fast basally. Skin biopsy, periappendiceal lymphocytosis, or virtual cells are diagnosed. Virtual cells means leprous cells or foam cells. Virtual cells. Lepromin test. Lepromin test, Mitsuda reaction is a Mitsuda reaction occurs after 1 to 2 weeks, prominent after 4 weeks. Infiltration with lymphocytes, epithelioid cells, and giant cells indicates cell-mediated immunity, differentiates those mount immune response and those cannot. And now antigens are derived from armadillo deprived leprosy. Okay, so the most important point is type of leprosy is classified by lepromin test, while diagnosis of leprosy is done by clinical examination. Most importantly, acid-fast bacilli demonstrations by scraping method, skin scraping method, nasal swabs, nerve biopsy, and skin biopsy can be done like periappendiceal lymphocytosis or visual cells, positive visual cells. Okay, so today we will keep up to this. As per our teaching plan, you can see dermatology is for 2 days. Okay, dermatology is for 2 days. So tomorrow at the same time we will continue dermatology.
No problem.
Okay, okay, okay. Then tomorrow same time only.
Yeah.
Okay,
Thank you.
okay.